we'll go ahead and get started. I'm just going to very briefly introduce Dr. Joanna Hikaka, our visiting Fulbright Scholar here at the Center for Long-Term Care Quality and Innovation. She's been here in Providence in Rhode Island since March and will be here through the beginning of December. I will let you, Joe, speak a little bit more in depth to your particular expertise, but just briefly say that that Joe is a pharmacist whose research centers on pro-equity health interventions, which sort of underpins the topic of her talk today, particularly for older adults in Indigenous or marginalized communities. So I'm going to hand the floor over to you and let you speak in more detail about your experience and your expertise. Thank you.
Great. Thanks, Rosa, and thanks for the opportunity to talk today. I really appreciate everyone taking time out of their day to come and participate in this. I just wanted to start by acknowledging that Brown University in Providence, Rhode Island sits on the lands of the ancestral homelands of the Narragansett Indian tribe. And I guess I'm always reflective of my position as a visitor on these lands, and the Narragansett tribe whose descendants remain as a strong and sovereign nation today. So as Rosa said, my background is in pharmacy. I've been a pharmacist for 20 years, but have moved more into health services research with a particular focus on Māori health and older adult health. And so a lot of the work I'm involved in sort of spans across health services research, equitable approach to health service delivery and design, and then usually with a focus on gerontology. And today I will be talking to you about a project that I'm working on in New Zealand, as well as a project that I'm working on in the US while I'm here. I just realized I don't have the presenter view, but that's okay. So kia ora everyone, that's the traditional, the Māori language way of saying hello informally. And this is a snapshot of the South Island of New Zealand, trying to entice people to come and visit. Always happy to host people in New Zealand. So today I'll be talking a bit about the Indigenous population in New Zealand, a bit about the New Zealand health system, and give you a very brief introduction to the New Zealand research and New Zealand health research setting, and thinking more then about the RAPT tool and talking about specific research projects. So I am from Auckland, New Zealand. New Zealand is located next to, but not part of, Australia. The population in New Zealand is 5 million, and the population of Auckland is 1.5 million. So the same population as Rhode Island. The life expectancy in New Zealand is almost 82 years from birth. I just wanted to introduce you a bit about Māori and Aotearoa New Zealand. So Māori make up 16% of the population, but that can vary by region, up to 70% in some more rural areas. And around 20% of the Māori population do speak the language fluently. There are around 100 tribes with many more sub-tribes underneath that. The Treaty of Waitangi, which was signed between the British and Māori, is New Zealand's founding legal document, and it also sets the precedent for Māori's right to equitable health outcomes in the contemporary context. And so although we have that legal mandate, there are inequities which exist across the spectrum of clinical contexts, which ultimately manifest in Māori having a much lower life expectancy than non-Māori. So although the life expectancy for the general population is almost 82 years, for Māori males it's only 73 years. And similar to other cultures, older Māori hold a revered position within traditional and contemporary Māori society, and with more acceptance that that's in the mainstream as well in New Zealand. So we'll often have older Māori or kaumātua that will sort of uphold the cultural practices within even mainstream governance and advisory groups. And the picture on the right is of Sir Mason Jury, who is a Māori psychiatrist and has been instrumental in developing, articulating Māori concepts and how they relate to health. And one of his models of health, which centres on multiple components of well-being, Te Whare Tapawhā, is sort of central to a lot of the health services we develop in New Zealand currently. I talk about the New Zealand health system because it is one health system. We almost have almost universal public health coverage in New Zealand. As a result of this, the New Zealand government dominates all aspects of healthcare, so regulation, compliance, funding, and quality measures. It's also the main supplier. So although about 35% of the population have public health insurance only, private spend on health only makes up about 5% of the national spend on health. We have a very generalist approach to primary health care. So where you have family health physicians or geriatricians, pediatricians providing primary care, we almost exclusively have general practitioners providing care, and it's more of a cradle to grave approach. So a general practitioner or a GP might see my child, might see my grandparents, and would see me as an adult as well. So I live and work in Auckland, New Zealand, a population of 1.5 million. I only know of one private geriatrician, and that's someone that works in the public sector and has, you know, a few private clinics. So access to geriatricians and specialist geriatric care is always through secondary care and referral by a GP. We also have access to routinely collected national data, so health data such as hospitalizations, pharmaceutical dispensings, emergency department presentations, injuries, and that can also be linked through geographical location to other determinants, social determinants of health, such as employment, education, and housing. Another unique feature of the New Zealand healthcare system is our injury compensation scheme. So we have a national no faults injury compensation scheme. So if you fall off your bike and injure yourself, if you are assaulted, if you commit if there's any self-harm, if you commit an offence, so if you burgle someone's house and you cut your arm going through a broken window, that's all covered by ACC, or the Accident Compensation Corporation, and it works like an insurance company, and it's funded through government taxes and also an employer contribution. So if you're self-employed, you pay an ACC contribution. Not only does it pay for the medical or surgical care related to injury, it also provides compensation for loss of work income and loss of quality of life. And when we talked about earlier about inequities in health outcomes by ethnicity in New Zealand, with Māori I guess faring worse, that also extends into ACC services. So ACC know that Māori are less likely to access ACC care, and there's less funding proportionately going to Māori for injury related care. That's not saying that Māori injure less, it's that the accessibility of services is an issue. And so this was known by ACC, and they put out a call for funding, asking for research projects to, I guess, address these inequities for Māori, particularly for older Māori, because although they knew inequities existed in the general population, information on what was happening in the older adult population was unknown. And as they are operate like an insurance company, they have a really strong interest in prevention and quick rehabilitation from injury as well. And I'll talk more about that RFP, the funding call that went out. Just to give you an idea and the difference between New Zealand and the US in terms of health spend, New Zealand are probably middle of the road amongst these OECD countries, with the United States having a higher spend. And when we look at R&D, so this isn't health specifically, but it gives a good indication. New Zealand have about 1/3 of the funding, as a proportion of our GDP as the United States. So we do need to, be really aware of the money we're spending on resources. And that sort of, I'll talk about that a bit more through the presentation as well. So when ACC put out a funding call, the University of Auckland joined in partnership with a iwi-led or a tribal-led organisation to develop a research proposal with the aim of testing the feasibility and acceptability of an injury prevention intervention in older Māori in the tribal area of interest. We were successful with that funding call, and our proposal and what we are doing, it was a multi-phase project. The injury prevention and actually rehabilitation intervention is being delivered by a community navigator, so someone that connects up older people and their families with care, with social services, with health, with things like podiatrists, physios, general practitioners, any sort of supports with benefits and social services. And as I said previously, this was, I guess, in response to what we knew, that there was inequitable access for Māori to injury-related care in New Zealand. So just really briefly, the multi-phase project, we're establishing an evidence base, so understanding what injury looked like in this population. We're co-designing an intervention, testing the intervention that we co-designed for feasibility and acceptability, and then making recommendations. So I'm now moving into more of the work that I'm doing relevant to work of the centres here, and thinking about a pragmatic approach to research. And I've got to admit that when I sort of first started talking to Rosa about, research opportunities, for me, a pragmatic approach was something that made sense, what makes sense. So, that very broad understanding of pragmatism, the quality of dealing with a problem in a sensible way that suits the conditions that really exist, rather than following fixed theories, ideas, or rules. And that's in comparison to a very specific definition of a pragmatic controlled trial. We're testing something that we know has proven efficacy, but looking at the real world application and implementation and effectiveness of that. So work that Professor Bayer et al. Did was to prepare this readiness assessment for pragmatic.
Oh, if you had an earphones on, just listen.
Oh, sorry, I'm just moving on. For pragmatic trials, so the RAPT tool, and a group of researchers got together and thought about the fact, well, we don't have established criteria to assess these efficacious interventions to understand if they're ready to progress to pragmatic controlled trial. And of course, we know that the reason we do a readiness assessment is that we're not wanting to sort of waste resources. We're needing to ensure that the intervention we're testing is likely to that we know a lot about the intervention we're wanting to test, and that there's likely to be a robust mechanism for testing that intervention in the real world. Sorry. And so the RAPT tool identified 9 domains that were important to review prior to progressing an intervention to a PCT. And the tool also provides a qualitative guidance around how to assess each of these domains, and I will talk through more of the domain, each of these domains as we go through, but it's things like, do we have evidence? Do we know that there's efficacy to support this intervention? What are the potential risks of this intervention? Is it safe? Stakeholders, do they think this intervention will be adopted? And does it align with their priorities? So it's thinking about actively reviewing an intervention prior to, I guess, implementing it in the real world. And when we looked at this, it made me think sort of about, well, is this applicable in Indigenous settings, and are there any modifications that need to be made? And I say this in the context, so we've talked about New Zealand and the smaller research budget, but also the fact is we're just a smaller population, so we often look to international examples and models of care to help us develop what we're doing in New Zealand. So do we really need to invent the wheel all the time? Do we need to start from the basics? Well, no, we don't in New Zealand. We don't need to always start from basics for Indigenous research either, but it's thinking about what modifications are appropriate in the local context, and that's always really important to the work we do. So when I talked to Rosa, we thought about, well, could we think about modifying the RAPT? Would it be appropriate, you know, should we look at the appropriateness of using RAPT in the Indigenous setting? And because RAPT was originally sort of brought together out of the Impact Collaboratory, which is obviously looking at dementia-related interventions, we had that focus. So the aim of the work, some of the work that I'm doing here, is to explore the appropriateness of the RAPT model for pro-equity health intervention development in the United States and New Zealand, with a focus on Indigenous dementia-related interventions. So the methodology we used, we developed a questionnaire, and it's an online questionnaire. There's quantitative and qualitative data collection, and it's modelled around the domains of RAPT and really asks the respondents to talk about how appropriate that domain is in the context of Indigenous research. So for example, you know, this is exactly what one of the questions looks like. So respondents answer on a Likert scale, and then also they're asked if it's not appropriate, what modifications would they recommend? And people are also asked to comment on their reason for responding in the way they do. And so we've gone through, and we had 22 respondents to that survey. It was quite a long survey. It required people to sort of engage with it and think about responses. 2/3 of the respondents were from New Zealand. Now this was sent out during the US summer. By the time, so this is another difference between New Zealand and US research. Although the participants in this research are only researchers being asked to comment on their professional experience and knowledge, New Zealand does require ethics approval from any research that involves humans. So we had to go through an ethics process in New Zealand with an agreement in the US, and it took a bit of back and forth. 40% of respondents were Indigenous, and more than 2/3 had a PhD, and people had up to 40 years of research experience generally, and up to 18 years of experience in Indigenous research. And so the average was around 25 years research experience and around 6 years experience in Indigenous health research. The general comment from the findings was that there needed to be a reflection of equity in the RAPT tool, and that came in across multiple domains. So what I'm going to do now is go into a bit more detail on each of the domains, and so 5 of the domains, and sort of talk about what changes participants thought would be useful. So when we're looking at evidence, the RAPT tool asks us to think about what the evidence base is to support an intervention. So participants asked, well, whose evidence counts? So who are we taking? Is it only randomized controlled trials? Is there value in Indigenous knowledge? And I think here's where we sort of come into those conversations about epistemology and axiology. So understanding what is knowledge and what knowledge is valued. And I guess that really explicit interrogation of that from the research team is something that's really inherent in Indigenous research methodologies that I'm used to using in New Zealand. So really thinking about your positionality and being open to understand that, you know, evidence might come from things other than randomized controlled trials. The need for evidence actually crossed multiple domains. So although evidence was a domain in itself, people said, well, we still need evidence of the risk in a target population. We need evidence that the outcomes are meaningful. We need evidence that it's going to be feasible in these populations. So it crossed multiple domains. There was also the question of what happens when no evidence exists. So you've got this intervention that's been shown to be really beneficial internationally, but there's really no indication of what whether it might be efficacious in the Indigenous population that you're working with. And so that was something that people brought up. Well, would it be right that we just wouldn't go ahead when we don't know this, or can we sort of do an analysis and think about pragmatically about how we might approach this. As I go through each of the domains, I'm going to talk about how we sort of did this within the injury prevention project I'm working on. So we knew that we didn't have evidence in our iwi area. So that the tribal area we're working in has a population of around 350,000. Up to, around 40% of that population is Māori. And it's an area that is more rural than other areas in New Zealand. And so we were able to access our national data sets and apply sort of, and just look at the cohort that was relevant to our region for a 5-year period to understand the incidents and characteristics of injuries for older Māori in the area, so that we knew the type of injuries people were having and therefore the type of interventions that might be effective. We also looked at ethnic variation in the region as well to understand, I guess, the access to care and high quality care. So we also, as well as using that secondary data from nationally collected sets, we looked at the international, national and local data relevant to injury prevention. So we knew that, strength and balance exercises were important, that driving assessments might be important. And then research that focused on Māori specifically showed us that home assessment and the subsequent modification to address the safety issues in the home that increase the risk of falls were important. But interestingly, and this is where we think about evidence, so even though we had research focused on Māori in New Zealand, this home assessment and modification study only looked at, only included people who owned their own home, because in New Zealand, you can really, if you're renting a house, it's really difficult for you to, it's not a guarantee that landlords will accept modifications made to those homes. So even things like pinning something on the wall is not, generally okay. So although we had some of this research, we did a really good look at how that applied to our setting when the majority of people in our setting don't own their own homes, as an example. We also had evidence that the role of a community navigator who we were wanting to deliver this intervention is effective for other conditions. So effective in diabetes, effective in cardiovascular disease management, but we didn't have evidence that there was effectiveness in injury prevention or access to injury-related care. So that's sort of the reason we did that, developing that evidence base to start with, so that I guess that the intervention project that I'm talking about from New Zealand is really focusing on developing, trying to develop an intervention that we could test in a pragmatic controlled trial later on. The implementation protocol. So, everyone was in agreement that you need an implementation protocol because that tells you what to do. Ethics require it. Is really important, but people felt that there needed to be explicit equity considerations included throughout. There needed to be inclusion of Indigenous communities in understanding how implementation would occur, and that the implementation protocol should be co-designed. So people, the research team, providers, but also people that are likely to be receiving the care, working together to develop this. It was felt that the implementation protocol should be easily understood for communities. Some people, the implementation protocol talks about the ability to replicate. And so some people said, well, why are we wanting to, we don't need to replicate. And Rosa and I have talked about this, and I think, there's potentially a change, the phrasing around that. So it's about the ability to replicate. So being really thorough in the reporting of exactly what you're doing so that people understand what you did in a research project. And of course, there will be settings when you do want to replicate in other environments and other populations. So our implementation protocol was co-designed. We interviewed over 50 older Māori, their family, community navigators and others involved in injury prevention and rehabilitation service provision to understand how we might implement this. it was intensive interviews, and these interviews were undertaken by Māori health providers that already were in these communities. People had the option of being interviewed in Māori or English. And there's a full process evaluation that goes along with us implementing this, so we're understanding any modifications that are made along the way. Feasibility. So when we look at this domain, it's understanding how likely we are to be able to implement this intervention in the existing conditions. And when we're thinking about this domain in Indigenous populations, or populations that as a result of I guess the structural marginalisation, there's inequitable distribution of resourcing, then this is a really important question, I think, as a research team. So what is our role as a research team to be advocating and ensuring that in our research processes, we are, I guess, accounting for an environment where the resourcing may not be equitable? Would that be enough to prevent us from going ahead? So some people sort of said, well, maybe this needs to be looked at differently. Maybe it needs to be thought about, is money the only limitation? So if resourcing was unlimited, would the implementation of this intervention be feasible? And other people also thought about including the aspect of it being strengths-based, so understanding the strengths and opportunities in Indigenous communities that mean that this would be feasible. So that resourcing wasn't just about the finances, it was about community strengths that meant that this might be successful. And some people also suggested about creating potentially a toolkit for community use, and it's potentially similar to the implementation protocol for use in the community. So, you know, making it, you know, incorporating those sort of aspects to make the intervention more feasible, or delivery of the intervention. So these photos, of some of the photos you'll see, are from people as part of our research. These are two of the community navigators, and these photos are all shared with permission. So the vast majority of our, so not the majority, a really good portion of our research budget actually goes towards funding the staff delivering the intervention. So we aren't asking providers to fund staff to deliver this intervention. It's part of our research budget line. And not only that, we're also working with funders throughout the project to think about sustainable funding mechanisms going forward. So we're already generating some contracts to increase the potential feasibility of delivering this service as we go. And that's really purposeful. So we have 8 weekly meetings with stakeholders. We talk about the fact that we're wanting the potential for these services to be funded at the end, and trying to get commitment throughout that this is occurring. It's been useful. We've through this work and through engaging this way, we have been able to obtain some funding, extra funding mechanisms that will extend the potential for intervention delivery past our project end date. For us, COVID-19, although we thought we'd plan for as much as we could, feasibility of delivering this intervention during the pandemic was an issue. So we'd planned for lots of things. We had felt that ethically we could undertake this research during lockdown conditions. So in New Zealand, we had quite strict lockdowns. So a lockdown in New Zealand meant that only essential services were open. Essential services were health providers and supermarkets. So no corner stores, no restaurants, no takeaways, no retail. Petrol stations, you could provide petrol, but you couldn't go into the station. You had to sort of contactlessly pay for that. We weren't allowed to leave our house unless we were walking, so we weren't allowed to drive anywhere. And so our university site was about 3.5 hours drive from our other regional sites, so that you know, there were geographical boundaries as well. But So we managed all those processes. We managed working through lockdown. We managed this collaborative, co-design process during lockdown. But what we, the major thing for us was really that the staff who we intended to be community navigators were being redeployed across the region for sort of vaccination delivery and developing community isolation sites. So there was a strong push in New Zealand for people that couldn't isolate safely in their own home with COVID-19 to be able to go to a community site where people with COVID could go, and so the rest of the family could remain in their own home without reducing the potential for spread. So the redeployment of staff caused issues with us for feasibility, and I'm guessing that feasibility in the COVID-19 setting is always going to be, is going to be an issue right now, potentially for years still to come. We also had intended that the study design would be a stepped wedge crossover trial, but because of the way that the staff worked between our 3 study practices very collaboratively, they had shared training sessions, it just wasn't possible to ensure that there would be integrity of the providers not sort of, I guess, learning and then applying those learnings as we went. So that's when we've sort of changed it more to feasibility and acceptability with exploratory efficacy. So we are looking at outcomes from national data sets and from healthcare access, but only in an exploratory manner to sort of look at the feasibility of that data collection. Acceptability and alignment. So in the original RAPT tool, it asks about how acceptable, like whether the stakeholders, whether the providers are likely to adopt the intervention after the research is finished. During the research, but then into the future as well, and how it aligns with their priorities. And sort of almost universally with the participant feedback was that the communities needed to be included in acceptability and alignment as well. Taking it a bit further, there was the issue around the power dynamic and people asking, well, if stakeholders, for example, don't agree that equity is an issue, they don't agree that potential modification is required for Indigenous communities, they don't agree that might be the way to do it. Where do we draw the line in saying that's sort of a racist approach that's preventing potential for good health care and improvement in quality of care? And so that was interesting. So it sort of takes us back to, yes, we do need providers to be in agreement, otherwise this isn't going to work. But I guess then the potential for more work to be required to go in there to ensure that providers understand equity, understand adaptation, and understand the need for this type of research. So in terms of our acceptability and alignment, that's when phase 2 was really vital. So that's where we sort of developed an intervention based on what people said was needed. And so that's how we sort of ensured acceptability and alignment. It also meant that during COVID-19, when it was really tough, the tribal provider was still really keen for us to continue with this research. So I said, well, perhaps do we want to, put a hold on it for a bit? And they said, no, we need to keep going, we need to keep going. So that enabled us to continue with this research. And this is just a picture from one of the marae, or the meeting houses in New Zealand, where some of our participants are together for a group activity as part of the intervention. Risk was another big one, and I think so understanding whether the intervention is safe, and I think a lot of participants will say, well, safe in what respect? So we need to know if there's risk from an intervention itself, so clinical risk, but we also need to understand the risk from research. So when we think about Indigenous populations and the fact people that are, the potential for over research, but also the historical exposure and experiences of research, which have been extractive have been for other people's purposes, have, you know, delivered us those tropes of the noble savage, the, you know, sort of hypersexualized Indigenous woman, then risk of research sort of takes on a different meaning. So they felt that it was really important to understand that there could be risk from an intervention, but also risk of research. They also said if we're delivering an intervention where there's the potential for risk, is there any level of risk that is acceptable? So some people felt that this actually should be looked at as the first domain and really fully explored before anything else was considered. So when we look at risk in our research project, we've actually had this recently where the number of assessments and the way they're administered was creating a real research burden on participants. And it meant that it was impacting on, you know, what's an intervention, what is the intervention versus what's the assessment. And so we've had to really look at how we deliver those interventions, how we I guess extract that information from people, how we engage with people, and thinking about as well whether we just need to cut back on the number of assessments we are collecting. So in the hope that we were sort of developing a robust evaluation, we were using international outcome measures such as fear of falling scale, the geriatric depression score, and also local measurements, and I will go on to talk about that soon. So it just meant that there were a lot of assessments being done. We also were using an iPad to collect the data, and that was a potential barrier, and it actually slowed some people down. So we've moved with some people to using the physical paper, but you know, in terms of feasibility, we're using that iPad and developing the data collection tools in the background to create a more feasible potential in the future. There's also the protection of knowledge, and this is another concept within Indigenous methodologies, understanding who guards the knowledge, who protects the knowledge that's given. And so we've built mechanisms in that the members of the tribal organisation have overall say in how research is presented and contextualised, not only in the academic publications, but also when we disseminate that to stakeholders and to also back to the participants and their communities. And we also ensured that people from the tribe were those that were collecting data as well. So there was that added level of comfort around that for participants. And this is just an example of measurement. So this is one of the assessments that the community navigators are doing, and it takes a holistic approach to health, and it asks people to sort of rate how they think they are amongst all these different domains of health. And so these tools were usually completed by hand prior to this intervention, and so we've developed some tech that goes behind it. It can be done online electronically, and then we're measuring changes of these over time of intervention as well, so pre and post, to look at that. And then the intention is that we're wanting to see how that's associated with more of these internationally validated tools as well, to see if we can see any correlation, and therefore the potential to reduce data collection and assessment burden for participants in future research. This research is now available. Sort of the study protocol for this has been written up now if people are interested in looking at this more. That QR code will take you to the link. And we also asked participants not only to comment on the domains that were there, but also what else might need to be added. This picture is, I guess, my picture of talking about what our research partnership during COVID looked like. So we had those various levels of lockdown, and in August last year, Delta entered New Zealand, and at that point we had very low vaccination rates because we had zero COVID in our community. And so Auckland was cut off from the rest of the country. Auckland's on a very narrow strip of land, which the police were very able to effectively manage the northern and southern borders. So our research team in Auckland were in our homes, but the people in Aotearoa, the tribal area, could still continue to meet in person. So we ended up, after delaying this for a number of times, we ended up saying, right, we just have to have some of these meetings. And that's a picture of us having our meetings in our team t-shirts. So in terms of these extra domains, health equity, some people said, well, potentially we should pull health equity out as a separate domain, be really explicit about that, whereas others felt there should be explicit inclusion across domains. That there should be a domain that looks at Indigenous involvement / partnership / leadership / support. So thinking about those various levels of Indigenous involvement, and so potentially that low readiness could be Indigenous involvement, but high readiness could be Indigenous leadership. And I think this next point, a domain that includes the cultural humility of the research team, I think that was really interesting and important. And I think we often approach this thinking, well, is the site ready? But thinking about, as a research team, are we ready? Are we the most appropriate people to be delivering this research, to be leading this research? An interesting aspect of that funding call from ACC, which led to this project, New Zealand project I've been talking about, was that they required a Māori PI, principal investigator. So they required that this project be under Māori leadership. And so that, and I think that's been instrumental. So I am on the PI on this project, and funders still go back to just asking me my opinion, and it would be really easy to tell them my opinion, but we've made this this agreement, we've made a partnership with the tribal organisation that decisions will be shared, but that the tribal organisation will have ultimate say. They asked the university to hold the contract because they'd never held a large research contract before, which is why, I guess in the ideal world, the tribal organisation would be holding the contract. But it's always important for me as the PI to be reflecting on my role and ensuring that I'm sort of going back to the tribe all the time around decisions that are made. The other domain was thinking about whether the Indigenous health advancement was really key to the project. So was it about doing research for research's sake, or was there the intent that there would be Indigenous health advancement as a outcome of the research? So what's next in terms of the RAPT tool? All participants have given permission to be contacted for interview. So as well as going into further detail around each domain, it's thinking about, I'll be asking people about whether they think there are any additional considerations for Indigenous populations specifically. So a number of people reverted back to sort of a more general health equity discussion. So just really drilling down on whether there needs to be explicit thought to Indigenous populations. And then people also reported that a comprehensive guideline might be useful too, so getting more information about whether that would be useful. So the majority of people said that they would use the RAPT tool in their normal practice, in their future practice as it was, because they were already sort of thinking about these health equity aspects. And then some people said they would use it, but only if it had been modified for Indigenous populations. I am getting close to the end of my time because I was wanting to leave time for discussion, but I just wanted to talk, I guess, about pro-equity service design and what that means. So when I talk about pro-equity service design, I mean being explicit in our intent to deliver equitable outcomes and putting measures in place through each of the steps to ensure that. So, a lot of people say if you're not designing for equity, you're going to have an inequitable outcome. So that you need to be explicit in that design. And I teach this, about this picture. I'm sure all of you have seen this picture before. So this picture is really good at telling us what the difference between equality and equity is. But I think we need to move past this. And I think, that that we run the risk of, if we're thinking about equity just on this sort of image alone, we might run the risk of missing some important aspects. So, you know, firstly, for me, if we look at the fact that the size of the people is different in these, there's the potential for us to think that there's something inherent in the culture and the population that means people are less likely to have these, achieve these health outcomes without understanding that it's the environment and the structures around us that that really drive these inequities. We need to think about the resource, so it's not just about increasing money, doubling the resource. It's about thinking the fact that these resources might be different. So it's not just about having 2 boxes. It might be that someone wants a ladder, someone wants, I don't know, a shovel to dig under the fence to get access that way. So it's thinking about, you know, the type of resource going in might need to be different. Outcomes. Now, when I talk about this in New Zealand, I always say, who likes baseball? And no one puts their hand up. Now, this isn't going to fly, I know, in the US. And after being to a baseball game here, it's not flying for me either, because I really enjoyed the baseball game. But, you know, the point being that if we're thinking everyone wants the same outcome, that's not the reality. So we need to understand the outcomes that are important to the populations we're working with. The other aspect is, and this is where this diagram's great, if this person, you know, that can't see over the fence is just looking through the hole, if they've never experienced what outcomes could be, what positive health could look like, what wellness could look like, then how, you know, then how do we approach, you know, populations like that where, you know, inequities, poor access to care has always been an issue. How do we sort of understand outcomes that are important in that space? The other thing is thinking about risk. So the person in yellow pants, yellow trousers is standing on the ground compared to the person in the purple t-shirt who's standing on a number of boxes. Now, we work in the gerontology space. So if you fell from the ground compared to if you fell off 2 boxes, we know that the outcome from that fall would be much greater if you're standing on 2 boxes. So understanding that the risks might be different and that it's not just about increasing the resourcing that, you know, removes that risk. So understanding risks might be different, and of course that barriers are different for everyone. It's not the same barriers that everyone has, and if barriers are different, then methods used to overcome these barriers need to be different too. And the other thing is that, you know, just my last point is that people are diverse, communities are diverse, populations are diverse and fluid. So people move in and out of these. There's different levels of inequities based on very many different characteristics within communities, and just understanding that that's important as well when we're developing services. I just wanted to acknowledge the funders of this research, including Fulbright New Zealand, who I am here with. And if anyone wants to talk about what Fulbright opportunities are like, then I'm really happy to have those conversations with you as well. This is just a picture of our Strength and Balance program. So it was decided that the Strength and Balance program wasn't appropriate in its current form that was being delivered in New Zealand. And so in the area, so we've used Māori cultural practices. Can you still see the?
Yes, we can.
And so what I want to just draw your attention to, it's just going to be a minute, but thinking about strength and balance for older people and the movements that are happening here. So the change in elevation, movement of the feet, the twisting, turning,
I'm not sure we're seeing the video, Joe.
And so I guess my point there was just that the strength and balance, so the intervention we're developing, components of that are being tailored for specific cultural needs of the community. So using their own songs, their own dance, their own movements to incorporate those interventions we know have worked internationally, but putting, I guess, a local flavour to them. And that's all I had. I'm really happy to answer questions. Thank you for your time, everyone.
Fox.
Thank you. So interesting. I loved it. And I'm sorry we missed the little film. I have a question that harkens back to the observation that you made, that you were being asked to sort of be the spokesperson for the entire group. And that is, how did you work to determine that the voices that you were hearing were representing the feelings, mood, information of the group?
Basically, that if funders want to have discussions with us, then they include the tribe as well. They don't just come to me as, you know, so these emails, oh, can we use all this information for evaluation for such and such and such and such? And it's just me reminding them, well, let's have a discussion, because remember, I actually feel like they're trying to trick me out, because, you know, we said we were working in partnership, and I feel like every time they only ask me a question, yeah, so it's about, but I do see the role that in managing that, so managing people's expectations. So between the university and the tribal organisation, we hadn't worked formally, we had no formal agreements previously. So although we had contracts to manage this research project, we also developed internally our own agreement around our principles of working and what we would do and how we would work. So it's even things like research assistants that we bring into the project, students, that all goes through tribal governance as well to ensure that people are happy with what we're doing.
So you use the tribal governance as the focal point for getting buy-in.
Yeah, absolutely. So we and it's so we have a tribal advisory group specifically for the project. We also have over half of the research, the named investigators are from the tribe, and they are all have, you know, a number of those people have positions in the tribe of influence and governance within the different sub-tribes of the area. So and so we you know, and we've talked about this as the university, our expectations are that they are feeding back to the tribe, and that there's tribal buy-in in what we're doing, and that there's those processes from those investigators supporting that governance process.
Thank you. Great presentation.
We're going to open the floor up for any additional questions from those participating remotely.
Hi, Joe. A great presentation. When you reflect back on trying to recruit tribes or getting them to engage, what do you think was your biggest challenge?
So we would really struggle with recruitment into this project if we didn't have the tribal leadership as part of our partnership. Our ability to work with this tribal organisation, I guess, was fostered through previous relationships that some members of our research team had with some members of the tribe, and previous research, or just actually in previous communications with them that were respectful and, you know, and that I guess people felt comfortable developing this relationship together. So it did require us to have knowledge of, I guess, each other a bit before we entered into this research partnership. And so I think previously the other research projects, the tribal organisation had been a small part of a very university-led project, but they felt comfortable with the processes that, you know, that they could work with the people that were still linked with this new project.
Thank you.
I think also just ensuring that it was really clear that this was going to be done in partnership. And so I guess the tribe had recourse if that wasn't how they felt it was happening. You know, it was a very public announcement that this would be happening in partnership. So even when the funding announcement was made, we'd already communicated with the tribal comms teams to ensure that the messaging going out was okay with them. They incorporated their own messaging and had sign off from their CEO as well. So just, you know, making sure that, you know, right from the start, it was clear that there's that tribal leadership.
think we have time for just a couple more questions. I want to make sure some of our Hebrew Senior Life colleagues have a chance to ask questions as well. Susan, others on the team.
Great presentation. Thank you. I don't have any questions.
Joe, do you have any final thoughts for us as a group of people interested in pragmatic trials who are grappling with ways both to think about equity, but also to engage and partners in co-design and in the implementation of research?
I don't know. I think for me as an early career researcher, it's been a bit easier in a way that I really don't necessarily know how research usually operates and things. And so I'm coming into this a bit of a novice and learning as I go as well. And so I think, yeah, I guess if anyone had any comments for me around ideas they had to improve things or to increase the robustness, because at the moment in my head, I'm like, how are we going to actually evaluate everything that's going on? But yeah, so I guess just thank you for being there today. And if you did have any follow-ups, I'm really happy to receive those over email and continue the conversation.
Thank you so much. We've all really enjoyed your talk.
Cool. Okay, thanks everyone.